Good evening, everyone. Thank you so much for joining us for the June edition of the Scleral Lens Education Society's webinar series. My name is Ashley Tucker. I will be your moderator for this evening. I am so honored to have my friend and colleague, Dr. Julie DeKinder, as our speaker for this evening. She will be discussing streamlining the fit, smarter scleral lens selections based on the ocular condition. Dr. Julie DeKinder is a clinical professor at the University of Missouri St. Louis College of Optometry, where she also serves as Associate Dean of Academics and Director of Residency Programs. She is both a Fellow of the American Academy of Optometry and a diplomate in the cornea and contact lens and refractive technologies. She is a Fellow of the Scleral Lens Education Society and a member of the American Optometric Association and the Missouri Optometric Association. She is currently serving as the immediate past chair for the Association, of Optometric Contact Lens Educators and the Vice Chair of the Accreditation Council on Optometric Education. These are Dr. DeKinder's financial disclosures, and they have all been mitigated. If you are new to our CE program, just a couple of things I want to chat with you about. So if you have any questions, please feel free to put them in the Q&A feature or in the chat feature. We'll get to them at the end of Dr. DeKinder's lecture. In order to receive CE credit, you must be online for 50 minutes. You are welcome but not obligated to stay at the end for Q&A. And course handouts can be found on the SLS website library page after this evening. And then lastly, if you would like to receive instant credit, you do have to download the OE Tracker app. Once you download it, just open up the app, use the scan QR button, and just scan the QR code at the end of the presentation, and you will immediately get confirmation that you are getting CE credit. If you don't have the Tracker app, that is no problem. You will be getting a CE certificate within 2 weeks of this evening's webinar. All right, I am going to unshare, and Dr. DeKinder, the floor is yours.
Okay, thank you so much, Ashley. Such a kind introduction. I'm so thrilled to be back giving this webinar tonight. I had a wonderful time doing it last year. I'm looking forward to this year. I had the pleasure of sharing the stage with Ashley earlier this year at SECO, and she asked me to present, and we talked about a few options, and we came up with this one, which is something I had been toying with and thinking it was time to develop a lecture like this. So I'm glad I get to do it in this lovely, wonderful virtual platform. So thank you for joining in. If you have any questions, please put them in the chat. I'm happy to answer them to the best of my ability after the end of the talk. So we're going to really talk about what I'm calling streamlining the fit. I've been lucky enough to practice the type of optometry I want to practice for a long time, where I really specialize in contact lenses, and I have lots of experience fitting scleral lenses. And I realized years ago when I started fitting them that there were a couple ways you could go with fitting them. And what I wanted to do was make it as easy as possible for my patients, but also as easy as possible for myself. And so this whole lecture is going to be about streamlining the fit and kind of talking to you about what I do when I go through the fitting process for different ocular conditions, so that I can do just that, streamline the fit. And I have a couple of examples in here that I hope are helpful to you that I call one and done, because I'm really at the point now where when I fit a scleral lens, if I have to put more than one lens on the patient's eye, I'm kind of kicking myself later that day. So I really have a goal of one and done, meaning I put one lens on, I modify that lens, and that's the lens. Off of that lens is what I order. And so hopefully I can give you some tips on how you guys can be successful at incorporating that as well. This is kind of what we're going to go over here. Anterior eye anatomy, you have to, if you're going to be streamlining your fit, you got to know what you're fitting. A little bit about topography, basic design features, really barely hitting on that, and then initial lens selection for different ocular conditions. That's what I'm hoping the bulk of this turns into. And then I think along the way, I'm going to give you some good tips and tricks that I've learned through the years to hopefully help with some troubleshooting for these different sort of ocular conditions. what are my goals for each of you, for myself every time I go out there? Work smarter, not harder. I say this almost every time I lecture, and it's because I truly feel this way. And I think it's very important that if we can work harder, we're going to be more successful, and we're just going to make everything easier for everybody, including our patients. So we're going to talk about working smarter, not harder, all night long. We're going to do one and done, and I'm going to tell you that I occasionally have an exception to that, and that is if unfortunately there's corneal touch on your one lens. If you really went too flat and you've got some touch, or you miscalculated, then I'm probably going to throw a second lens on, but I'll show you an example where I don't. And I got pretty lucky there, but I don't like corneal touch. And so I don't like trying to combat it. I'd rather see the clearance and bring the lens down. And then my last one is, anytime, any place. So it seems like a weird goal, but I've done the bulk of my career at UMSL. I've worked at a few other places here and there, and I spent about 7 years working at St. Louis University. And when I walked into St. Louis University, they had a whole, the first day there, they had a whole list of patients for me. And all of them were going to be new scleral lens fits. And they had 2 scleral lens fit sets for me that were both the Jupiter set, which is great at the time. There weren't a lot of sets out when I started doing this. I had an 18-2, I had a 15-6. I didn't know what I was doing. I couldn't figure out how to get to a topographer. And so it really turned into using lenses to figure out what I was going to do. So that's why I call it anytime, any place. Hopefully you'll realize that you don't need a lot of extraneous equipment to be very good at fitting scleral lenses. What are my initial tips for success? Mini scleral designs. I rarely fit a lens that's over about 16.5. And I do that because I think it's much easier for the patient to put on their eye, for them to handle, and for them to adapt to. And I think it's a lot easier for me to make the changes I want to make. I can probably count on one hand the number of times in the last 5 years that I've had to go larger than a lens that is 16.5. A lot of the lenses when I initially fit were large lenses, right? Because they're big. You get a lot of room. You can make these really big changes, and you don't have to be so fearful of it. You don't have to be quite so nuanced with them. Now I really shy away from them. For one thing, when we talk about the toricity of the sclera, it becomes more toric the farther you get away from the limbus. So if we can keep that lens at a smaller diameter, then we don't have to make such drastic changes to the periphery of that lens to get it to be well aligned. My second key to success is peripheral lens alignment. When I look at scleral lenses on the eye, I spend about 90% of the time looking at the periphery of that lens and about 10% looking at the corneal chamber, right? Corneal chamber, boom. Do I have touch? No. Do I have clearance? Yes. Is it excessive? Yes or no? That's how I know if I'm going to make changes. And then I scrutinize the edges. And when I say the peripheral alignment, all on primary gaze. So I spend a lot of times temporal, nasal, superior, inferior, moving lids, but having the patient look straight ahead, because it really gives you the exact idea of what that lens is doing on the eye. And then you can use what you see in that slit lamp to determine if the lens is too tight, if it's too flat, what adjustments you need to make. I always start with a toric design. I'm never going to start with a spherical. I stopped doing that many, many years ago. So whenever I pick a lens, it's always going to be toric. And I will say that when you always select a toric lens, you will occasionally design a spherical lens off of it. And that is okay, because that's another thing I can probably count on one hand the number of times I've said I want to make this change and this change. And the consultant said to me, you just designed a spherical lens. And I'll say, great. That's what I want then. So you might end up doing that, but you're more often than not, you're going to need a toric lens. And I do all of my evaluations with some lovely white light, because it's really the best way to be able to see all the ocular anatomy features you need to see, including the cornea, as well as the lens, and see those nuanced changes. And then my last thing I was going to say is, be patient. Be very patient before you make any changes. Don't rush into changes. It's very, very rare. There must be something really wrong with the lens, like I'm off on the power of the lens by 3 or 4 diopters, that I won't dispense a lens that I don't think is perfect. And that's because I think that it's very important to be patient, to let the patient wear the lens for about a week. And then after they've had that lens on their eye for 4 hours or more, a week after they've worn it, then they're going to come back and they're going to tell you all about that lens. They're going to tell you what they love, what they don't love. And you're going to get so much more information about what that lens does on the eye throughout the day than you did at that dispense appointment, or at the fitting appointment. So always be patient when you're making your changes. So we're going to start our talk with talking about corneal shape. And this is one of the advancements that I am truly embracing and in loving in a lot of our newer scleral lens designs. And that is, we have options of picking an initial lens that you then don't have to design off by yourself, which you can design it. You can definitely use any scleral lens, and you can design it how you want, but you can actually now pick a lens that might be prolate to start with or oblate to start with, and that will actually help you streamline your fitting process. So if you think about a prolate lens, this is when you're going to have your traditional standard design lens. If you think about a corneal GP, a small corneal GP, you know, you've got a steeper base curve radius, peripheral curves all get flatter as you go out. All you're doing with the scleral lens is making it a lot bigger and doing the same thing. Back optic zone radius, base curve of the lens is the steepest curve. Your other curves get progressively flatter as you go out, 4 or 5 curves, however it happens to be. And you can see that in the picture here, that you've got the steepness here, flatter as we go out. You're going to put this on your corneas that have some sort of steepness. A normal cornea is going to be prolate in design. A keratoconic cornea with a large steep cone, prolate in design. So if you see that area of steepness, especially if it's nice and central, you know you're automatically going to say to yourself, I'm going to go with a prolate cornea. When we're thinking about corneas with like dystrophies, corneal dystrophies, dry eye, those type of situations, you're probably going to think, I want to start with a prolate design for these patients. Another one, high corneal astigmatism. You know, that's going to be another one that's rather prolate. We're going to talk a little bit more about some issues that can come up if there's too much corneal astigmatism, but that's also going to be prolate. So if you're fitting one of these for a high astigmat, I would think about using a prolate design. Or if I have an ectasia, corneal ectasia, keratoconus, we were talking about that, but like a graft that's actually prolate as opposed to being oblate. So now let's talk about oblate. And so oblate is different, right? So oblate is actually where that back optic zone radius ends up being flatter than your adjacent. So we're thinking reverse geometry, right? So go back to thinking about ortho K. When we think about it on the cornea, I always think that if you think small where you learned, then you can apply it to the big. So you think about an ortho K lens, your base curve is actually flatter than that secondary curve, which is steeper, right? So you've got this extra space out there in the limbal area. Then you're going to go back flat again, right? So then your peripheral curves beyond that will be flatter. And that's what we've got here is you've got flat, steep, a little bit flatter. And what that gives you is this type of lens here that's a little bit flatter, and you're going to have more space out there at the limbus. And then you can mimic a cornea that looks like this. It looks very oblate, right? So this isn't super prolate. This is definitely oblate. And when you think about a patient that may have gone and had a corneal transplant, a lot of times they have this astigmatism that's like depressed, right? So they have these oblate looking corneas you see on my patient down here. So you have to go with these oblate designs like this. So like that patient would be one. Here's one where you could consider an oblate design. Yes, you have a little bit of steepness here, but really the bulk here is flatter. So I would trend towards initially selecting an oblate design if I could. Now, if you're using a set that doesn't come with an oblate design, you can easily design it by incorporating a reverse curve into that lens and decreasing the central clearance. So you would just say to the consultant, you know, I ended up having 500 microns of central clearance and not enough out in the limbal area. I want to incorporate reverse curve. And a lot of times what they'll do then is flatten that base curve, steepen that secondary curve, and they're making you an oblate lens just from you designing it, even if you had to fit them off of a prolate design. So don't be handicapped if you don't have one of the sets that has both the prolate and the oblate. You can still think this way and incorporate those type of changes in there pretty simply. Okay, spherical lens, this just very basic. Here's a scleral lens on the eye. If it was spherical, you're going to have your central optic zone. You're going to have your transition zone. So that transition zone right here is where that reverse curve would be. So this can be in your prolate design, it's going to be flatter. In your oblate design, this is what's going to be steeper. And then you've got your scleral landing zone out here. Typically 1 to 2 base curves here, 1 to 2 here. So you can end up with 4, sometimes 5 peripheral curves there. Here's a lens. All of the lenses in my pictures are very well loved because I usually find them sitting on my desk. And when I'm thinking about taking pictures, so this was a lens that a patient loved a lot, but I love it because you can really see our central optic zone. You can see our peripheral zone, and you can very easily see that transition zone right there when you hold that up to the light. Reverse curve, this is when that secondary is curved steeper, like I said. I'm a huge proponent of always looking at invoices, taking a look and making sure that this lens is the lens I wanted it to be. And so I always look to see if I've got a traditional design or a reverse curve. I work with several other doctors. And so especially if I'm picking up a patient I didn't initially fit, I'm going to look in there and see what I'm dealing with so that it can help me direct any changes I might make. This lens happens to be 6 diopters of reverse because it's a 7.5 base curve, and then that secondary curve is a 6.2. And then you can see if you go then to that next curve, it flattens way out to an 8.7. So we go back to being flatter than your base curve because you've got base curve, reverse curve, and then you got to flatten out because you're going to be way flatter out there in that that limbal area moving into the sclera than you were at your central cornea. All right, so now let's talk about anatomy and shape. And we've got a lot of knowledge about this because we've been fitting scleral lenses for a long time. We have a lot of technology that's out in this area now, which is wonderful. So we had the scleral shape study. And what we know from these scleral shape studies is that your temporal sclera is steeper, your nasal sclera is flatter. Okay, so steeper temporal, flatter nasal, and whatever corneal toricity you see, it doesn't extend into the sclera. So don't expect those to be the same. And I'm going to say, just from the lenses I fit all the time, that typically I find that the steeper meridian in the sclera is at 6 and 12. So it's going to be on your vertical, and your flatter one is typically in the horizontal. That's just what I see more often than not, but that is definitely not a rule. That's just what I tend to see more often than not. The other thing to know is that toricity out there in the sclera is going to be asymmetrical, right? And remember, one side's completely steeper and one side's a little bit flatter. So we've got all this working against us, right? So if you have a flatter side and a steeper side and you have a big, large lens, and then we've got some irregularity and we're putting it on there and then we expect it to center up every time, we're just kidding. We're just kidding ourselves. And that's why it's really important to use a toric periphery lens. The other thing is, as you move away from the limbus and move farther away, the toricity in the sclera increases, or that irregularity increases. Okay. So in the scleral shape study, if you look here at what they found, out of 140 eyes, only 8 of those eyes are spherical. This is why I don't fit spherical lenses. That's why I always start with a toric, because it's just more often than not, you're going to need some toricity to get these lenses to align well out there. 40 were toric regular, then you had your asymmetric, and then your kind of your ones that were a little bit more asymmetric from that. So you can see the bulk of them are toric. And the real key to having a successful scleral lens is having a lens that's evenly aligned. And that's why you have to have that toricity, because you really want that lens to land evenly on the sclera. If you have a lens that's sitting out there on the sclera that's landing evenly, even if it's a tad tight, which is my preference, it's not going to cause blanching or discomfort for the patient. It's actually going to be very, very comfortable. But if you have a lens that's landing out there, but it's landing really hard at 3 and 9 and not at 6 and 12, not only is that lens going to end up being decentered, but it's going to cause some impingement. It's going to cause some congestion. So you're going to actually see some redness, blanching and redness, congestion. And it's probably going to be uncomfortable for the patient. They're going to say to you, I can feel this lens. I can feel this lens when I blink. And it's because that lens isn't sitting evenly and it's not kind of tucked in to the conjunctiva, which creates a much more comfortable fit. And that's why knowing scleral shape and understanding that toricity is out there is so important. The other thing, when you think about the difference in the temporal and the nasal part, is we end up getting lenses that tend to decenter temporally, and that can cause, conj prolapse if you don't adjust it. So you really, once you get them on the eye, if it's decentered in any way, the first way to combat that is working with the periphery. Tighten up that periphery to get it vertically aligned. To get it to where it sits up. If it's sitting inferiorly, you want it to sit up. You want to steepen your vertical meridian first, and then if you see any sort of like situation where your horizontal isn't tight enough, tighten that as well, and that's going to get your lens to center up. And that's the first step to combating conj prolapse. And the next thing you want to do there is thin out your limbal. Don't have too much limbal clearance. So a tight periphery and then decrease limbal clearance to where maybe 50 microns is going to help you get rid of something that looks like that. So all this knowledge is going to help you determine your initial lens design, because sometimes you might look like a lens, and this lens, I look at it and I say, clearly that lens is sitting inferior. So let's just check that. If I draw a line around the lens, there's my lens, here's my cornea. Okay, the lens is clearly sitting inferior, even though we've got a lid over the top here. But I think, is it really laterally decentered? And guess what? If I take a line that's this length and put it on both sides, it turns out it's also temporally decentered. So this is a lens that's actually inferior and temporal. So we need to tighten up that periphery all the way around in your two meridians, so that you could get that to be centered up better. And then you're going to be able to dispense that type of lens after you get it centered better, and then decide if you need to make any more modifications beyond that. But 100% you would want to tighten this periphery here. And in a second, I'll talk to you about how I know how much I like to tighten this up, because you're going to have to be a little bit aggressive here. And I think that being not aggressive is kind of a folly sometimes as practitioners. So we can be very aggressive and not be too concerned about it. Back surface toric lens design, this is what we're going to talk about. So typically two, you can do quadrant specific. I like the two base curves. I use those more often than not. Those will be 90 degrees apart, typically marked on the flat meridian with some sort of mark. So if you're fitting a toric lens design, it is imperative that you measure where those marks are every single time you see that patient without fail. The one time you don't do it is the one time you're going to need it. So I do it every single time, whether I did it the last time or if they were here last week and they look like there's the exact same spot. It takes me about 2 seconds to measure where those are. So I do it every time. When you look at this patient here, they walked in and they said, hey, I think there's something wrong with my lenses, Dr. DeKinder. And from, across the exam lane, I said, oh yeah, clearly I don't have your periphery adjusted right on those. They're landing way too hard horizontally. And that's why you can see this injection here. So if I see this, and I see it when I'm talking to them outside the slit lamp, and then I look in, I can almost tell you beforehand that what I'm going to see is that this is not necessarily too tight, but this vertical is definitely not tight enough. And so to alleviate this redness here, I'm not going to flatten this. I'm actually going to steepen the other meridian, because I want to increase the pressure here, because then it's going to lift up on that horizontal, and then we're going to have a better aligned lens. Okay. And I'm going to do that every single time. When we look at these, in case you don't know what this looks like, you can easily tell here, as is the lens that I'm showing you, two different views. Here is your steep. Your steep is left and right here. Here's the flat. Here's our steeps in the front here, and then you can see the flat. So that's how much toricity you can see, and you can have much more than that, but this is just showing a little bit of toricity. And then on the eye, you want it to look lovely like that. And there's those markings, right? So I take my slit lamp and I take my reticular and I line it up right with that. And then I read off the axis and I put that exact axis in my chart, so I know exactly where it is. I say that it's always the flat meridian, and I used to say that without fail. There is definitely one scleral lens on the market now that they put that on the steep meridian. So if you happen to use that one, make note that that's actually the steep meridian of those markings. Either way, measure the markings. And if you know the lens and the manufacturer, you can look it up to see if it's the flat or the steep. But, right now it's like 99% to 1 on them being the flat. So this gives us our equal pressure, and it can help us center. And you can adjust, all of these intermediately. And if you need to go to quadrant specific, you can do that as well. The nice thing is the lens should lock into place, and the flat will align with the flat, the steep will align with the steep, and then you'll have a very, very well centered lens that's not going to rotate. Okay, so I said I spent 90% of my time on this, and here are my tips to how you can be very successful with the periphery. My goal is a well-aligned, slightly tight edge every single time. So much so that I even say to my patients when I am making adjustments, I say to them, you may or may not know this about me, but I am rather aggressive with my lens changes, because I know that a tight lens is actually a more comfortable lens. And I think you're going to be happier if I go a little bit tighter. I have been occasionally known to go a little bit too tight. So you're going to have to tell me if I do that. If you have difficulty taking it out at night, if your eye becomes red after you take it out, I clearly went too tight. But I'm going to be aggressive. And the reason I'm aggressive on the front end is because I'm trying to save them lens remakes, trips back into my office, and me time. So I feel like I can make bigger jumps, less remakes if I do that. So if I'm looking in my slit lamp and I look at those edges and they are flaring away from the eye, so they're actually kind of flaring back towards me, then I'm going to say, ooh, that is a very flat edge. You might actually see lens movement. The lens will definitely be inferiorly decentered, and I am going to steepen that periphery whether it's 360 or just one meridian that's flattening. And I'm going to steepen it a significant amount. When I say a significant amount, I mean anywhere from 75 to 100, maybe even 125 microns. Okay, so if you're working with a lens that works in microns or millimeters, you can just go in those steps. You can go like a quarter step, a half step, 75 step steeper, and that's going to get you that micron change. If you're using a design that uses steps, which is what most of the designs out there are now, typically those steps are anywhere between 25 and 30 microns. So you're going to want to go 3 to 4 steps steeper to tighten that lens up. And do not shy away from that. It's okay. You can go 100 microns steeper in the periphery without harming your patient. All right. And especially if those edges are flaring back at you, you want to go that much steeper. Okay, now if I'm looking at it and I've got it a little better, but now it's just aligned. And what I say by aligned, it's just like, it looks like the scleral lens is just sitting there, right? It's not hugging, it's not flaring back, it's just coursing right along with that conjunctiva. That's not tight enough. I think that lens will probably end up getting some debris under it. It might not be perfectly aligned if it's just kind of sitting there. You really don't want to see that. So I'm still going to go steeper in that case. And in that case, I'm going to probably be a little bit less aggressive. I would probably go 2 steps. I'd go about 50 microns steeper the whole way around if I saw that. So if it's just aligned, I'm probably going to go 50 microns, which would be about 2 steps all the way around. If it's in one or the other, I'll just go in that one. Now, if I'm looking at the lens and those edges are diving into the conj, they're just hugging it, right? It's kind of a scleral hug. It's just hugging the conj just a little bit. And I did try and find a cute little like GIF of something hugging an eye, and apparently those don't exist. So sorry, no cute pictures here. If it's just kind of hugging the eye, that's what you want. You can leave yourself, you can pat yourself on the back, you can say, congratulations, I achieved it. I'm hugging the eye. This should be a good outcome. We should get no debris. We shouldn't get, they shouldn't get clouding as the day goes on. They should have a good visual outcome all day, and it should be a very comfortable lens. They should not be able to fill on the eye because it's just slightly hugging into that conjunctiva. So that's what you're going for there. All right, so knowing my anatomy and shape information, if I have a prolate cornea and a toric sclera, I'm going to go with a traditional geometry prolate lens as my first lens, toric periphery. Oblate cornea from the topography toric sclera, I'm going to use a reverse geometry lens / oblate lens, toric periphery. See, all torics. And let's say I have a highly toric cornea with a toric sclera. I'm probably going to start with a prolate design, traditional geometry lens with a toric periphery, and I'm going to monitor for decentration inferiorly that is not improving as I adjust the periphery. And we're going to talk about that more here in a second, because that's kind of a big thing that I've noticed on several lenses over the last year. So if you see this, if you tighten your lens up and it's still looking nice and low like that, we're going to have to talk about something we've got to do to fix that fit, which is not just going to be messing with the periphery like it typically would. All right. How we pick this lens, if we're going to streamline the fit, let's talk about how we fit it. Diameter first. Look at the HVID. Pick your diameter. If your HVID is 12 millimeters or less, you can go with a 16 millimeter or smaller lens. If it's 12 millimeters or larger, you probably need to stick around that 16 or go a little bit larger. And that's just ensuring limbal clearance. Okay, that's not a hard, fast rule, but it's what I like kind of follow with. If I'm hanging around 12, I'm fine going with a 16, 15, 8 millimeter lens. If it's, a little bit larger than 12, I'm probably going to skew to maybe a 16, 5. Ways to measure HVID. This is pretty easy. Everybody's got one of these in their office. Most people have this in their office. I don't use the slit lamp. I don't like this, but I think probably the most accurate would be this. So you can measure it off of your topography doing a chord. You want to do it at an oblique angle, because that's how you can see the most of the cornea, right? Because you're going to usually have lid interaction here. So you want, if you do it on if you take that chord and you measure on your topography, just pull it all the way across. You can see that's a 12 millimeter there. If you happen to have a pentacam, the horizontal white to white, HWTW, that tells you your HVID. So you can use that as well. So then you're going to pick your lens design, prolate, oblate. If you happen to have that choice, prolate versus reverse geometry, you're going to pick that. And then you're going to decide, am I going to do a spherical or a toric landing zone? I'm always going to do a toric if I can. Here's a couple of pictures just showing you, when you think about some of these sets that have these prolate and oblate lenses, I thought this was kind of cool. I tried to pick lenses that had very similar sagittal depths off the prolate versus the oblate side, and then took pictures of them side by side. So this is a prolate with a sagittal depth of 44 and an oblate with a sagittal depth of 45. And you can look at the base curve difference in these, right? This perlate one is a much steeper base curve, right? Because this is going to be steeper. And this oblate has this very flat base curve, this flatter base curve with more space out here in the mid periphery, but the sagittal depth is almost identical on them. So it's all about that corneal area. And that's why it's important to try to mimic that with your first lens, because you're going to have to make fewer lens adjustments because of that. Same thing here, same, almost identical sag, incredibly different, 50 down to a 46 on your base curve. So just something interesting to look at there. Base curve determination. How do we pick our base curve? Well, you can always use the manufacturer guidelines. These are excellent, especially on the newer lens designs. You can do this. I would say if they have a very streamlined way for you just to read something and then grab the lens you want, that's what I would do. Is that what I do? No, unfortunately, I don't do that because I'm even more lazy than that. And I do it on this. I always pick my first base curve off of a base curve that's flatter than the flat K. And I go 2 diopters or more flatter, depending on how I'm feeling that day, than the flat K value. I find that to be the most efficient, fastest way to pick a first lens to put on the eye. And it tends to be very, very successful. Now, I do think these manufacturer guidelines are very good, and I have dabbled a little bit with using those. What I don't really do is I don't use my anterior seg OCT or the Pentacam anterior seg map to pick a first lens. And the reason I don't do that is I find that it overestimates the amount of clearance. So when you kind of look at some of the literature that's out there, it talks about what you would do here on an anterior seg OCT is you would get a 15 millimeter cord. So you would take this anterior OCT, you would take a cord that's 15 millimeters, line it up where it matches up out here. In this case, we're out here, a little bit beyond, we're beyond our limbus, so we're matched up here. And you would take a second cord and you would measure your sagittal depth, so which is 3.47, 3470 in this case. And then what literature suggests is if you were fitting a 15 millimeter lens, great, you would take that and then you would add a few hundred microns for however much of clearance of the scleral lens you wanted. But if you weren't using a 15 millimeter lens, then you're going to have to adjust that. So if you think about it, if you're not using a 15 and you're using a 16 instead, it's going to sit out here farther, which is going to increase your sagittal depth. So what literature says is that maybe you should then add 400 microns if you're going a millimeter larger. Or if you're going 2 millimeters larger, 800 microns, or if you're going smaller, then you would subtract 400 microns. Well, let's look how this works in actual practice. So here is an image of the eye. I couldn't get a 15 millimeter cord with the image I had. I took it off the OCT. The biggest I could get was a 14 on this patient. So I got a 14 millimeter cord. It came out that their sagittal depth was 3074. So if I wanted to fit a 15 millimeter lens and I thought about the theory of 400, then that would be, we would bump this 3074 up to a 3474, and then I would add whatever desired clearance I wanted on top of it. And then if I wanted to go to a 16, then it would maybe be 38 because you would add another 800. In this case, the patient was already fit. The patient I did this in was already very successfully fit in a 15.5 millimeter lens, which would be theoretically adding 600. So if we added that in, it'd be 36, plus you would add additional clearance so that I could have some clearance up here minus settling. So maybe you would add 200 or 300 microns, bump your 36 up to a 38 or a 39. SAG, which is what I have here. What's their best fit lens? 34. The 3400 SAG was the best fit lens. Same thing happened with the other eye, 34 there. And so you're saying, well, what do these lenses look on the eye? Well, they look like they're a pretty good fit on the eye. Almost too much clearance. You can see the lens is sitting a little bit low. So the periphery of this lens does need to be adjusted, right? I would actually steepen this vertical. I would steepen the meridian, whatever meridian that is right here. I would probably take that 2 steps steeper personally. But then when you look at your cross section here, you can see the lens is sitting inferiorly. But when you look to see the clearance, you could almost even reduce the clearance another 100 microns, maybe 200 if you like to fit very, very close to where you could take that 34 SAG down to a 31 or a 32. And that's the reason I don't use the OCT. I truly think it overestimates. And also, by the time I took that picture, did all that analysis, and then determined what sagittal depth I needed to put on my patient's eye, I'm going to be very honest with you. By using either the manufacturer's guidelines or going flatter than the flat K, I've already worked smarter because I've already got that lens on the eye and I'm probably already evaluating it and getting ready to over refract it or vice versa, while that other person is still messing around with the OCT. So that's one of the other reasons I don't use it. I think it's very interesting to look at, but I find it to be a little bit of a time suck. Okay, let's look at some some different conditions here. Corneal scarring. So when we think about corneal scarring, you might have a situation where it may be elevated, it may be depressed, right? So this is a patient I fit, clearly has a scar. This is a scar from ulcerative keratitis that they have, and now they have this scar here, and I believe that it is elevated. So if I'm going to do a scar, I'm going to think it's probably going to be a normal cornea, unless proven otherwise by topography, and it's going to be pretty normal and regular, except for the irregularity we're getting here. So I'm going to pick a mini scleral design because I just like those better. And I'm going to go prolate because it should be normal. Now, if my scar was here and it was depressed, that might change. I might choose like an oblate thin. This scar's right out here. If it's elevated, it's not incredibly large. I think a prolate is going to be my best first lens. So here is the topography for that. And you can see we have a small area of steepening, some corneal irregularity, and I did go with a prolate lens with a flat base curve. I did a 40 diopter, and when I told you I typically fit 2 diopters flatter or so, you can see their flat K was a 42, so I followed what I typically do there. It was a 16 millimeter, and then the sag was a 34. So that's how I picked that first lens, went with a prolate design, mini scleral, patient can handle it very easily. A few concerns about scars. Sometimes scars can become concerning, right? So this is a post-herpetic scar, and it did not have any of this neovascularization when I fit them about 7 or 8 years ago. None, zero, zip, zilch. And I monitored them for several years. And it slowly progressed and progressed and progressed. I made all of what I consider to be the appropriate modifications to address neovascularization, which is thinning the lens, decreasing the clearance, maximizing the oxygen for the lens material, and yet the neovascularization progressed. So you have to determine at which point you're comfortable with some neovascularizations in knowing that you've incorporated all the best changes you can and when you are not. In this case, this had progressed to the point where it was really starting to get very close to her visual axis and I was becoming uncomfortable. So I actually sent them for a referral, and they had the yellow laser treatment that actually photocoagulates that neovascularization, and now she looks like this. So it's all gone. So they can either use an argon laser or a yellow laser, and they can photocoagulate those vessels, and then you can lose the neo. And then I'm just monitoring it now. So how do you maximize oxygen if you're worried about neovascularization? Highest DK material possible. So thinnest lens possible, 250 or lower. And then you want to decrease that center thickness, that tear film, to 200 microns or less if you can do it. And your limiting factor there. So if you put them in that 200 DK material, fantastic. And you've got it down to a 250 millimeter lens thickness, also wonderful, but truly it's the tear film that's a limiting factor. And there's some new research that's come out that's really saying you got to keep it at 200 or less. So you got to fit these as close as possible, which is why mimicking the corneal shape with your initial lens is going to help you achieve that better. So really mimicking that is the best you can. Here's a patient that I've done all of these things to. They have this little bit of neovascularization. I've made it as thin as possible. I've maximized the DK. And I fit it as close as possible. And you can see that by these images, how close we are fit here. And they just have neo, and I just take pictures of the neo every year to make sure it's not advancing there. Keratoconus. I think most people are fitting, if you're fitting scleral lenses, you're fitting them for keratoconus. It should be pretty obvious you're going to use a prolate design here. I like to use a mini scleral. Remember, if you do have a scar like this guy right here, this might impact your visual outcome. But if you have a lovely central steepening right like that, prolate design, right? Pretty straightforward to do a prolate design there. And here's the thing about these prolate designs and picking that initial lens. If you see something that looks like this, right? So this max K is like a 72.2, looks like it's a massive cone. That's your tangential, right? Looks like it's a massive cone, pretty steep Ks. Do not talk yourself into fitting a steeper lens. Do not walk into that diagnostic room and say, Julie, I'm not going to go flat. I'm going to go steep because that's a massive cone and I'm going to have touch. You're probably still not going to have touch. Go flatter, feel comfortable, pick that flat lens. If this was a 58, I'd go with a 55 or flatter lens. Base curve is my initial lens for this patient. And don't be afraid. If you have touch, you can always go steeper. You're likely not to have touch. Okay, so what if you have a patient that looks like this? And you want to see if you can do the one and done. Well, I'm telling you we can do it. So let's walk through. I just saw this patient 2 weeks ago, and the patient never had a scleral lens on their eye. And I said, let's put one lens on him and be done. It must have been late in the day. And I was like, we're gonna one and done this person. Let's talk how we did it. So here's their map. there's their axial. I like to look at tangential, looks a little better. Central cone, steep Ks. K max, I can never find on here. Oh, 83, high K max, 52, 63, lots of irregularity there. You look at their front elevation, we got some low points, a little bit higher. How are we going to pick your lens? Well, I'm going to tell you right now, I'm going to look at this flat K. I'm going to go flatter than flat. Do I have an HVID? I don't have an HVID on this patient. So no HVID here. So I'm going to just go with a mini scleral. So I'm probably going to go with a 16.0 lens diameter, right? So around 16.0, maybe a 15.8, maybe a 16.5. We'll see which one I picked. I'm going to go with a prolate design because they are keratoconic, and I'm going to pick a lens that is flatter than the flat K. So let's see what I picked. Okay, so I went with a 48. So they're a 52. I went with a 48, which was a 4670 sag, and it was a 15.8 diameter. Okay, so let's see what I said about it. So here's that lens. I put that lens on the eye. And what did my chart say? It said central clearance around 200. So that's 200 microns with touch. Oh no, I told you I didn't like touch. I don't like touch. Oh, okay. So we have touch. That's okay. We're going to work through this. Over the inferior scar. All right. So the scars was causing my elevation and my touch. I definitely don't want to have touch there. Lens is inferiorly decentered. That's a bummer. Edge is flat in the vertical. Oh, and slightly flat in the horizontal. Okay, so what I'm saying there is I'm flatter here and I'm a little flat here. So we're gonna have to fix that. Oh, and I measured where the markings were. Okay, so that's what my chart said. So what did I do? Well, a lot of times when I have touch, I do take that lens off and put a new lens on. In this case, they were not very easy to get the lenses on the patient's eye. And I said, you know what? This lens hasn't been on the eye very long. So I do think it's just touch and not touch, right? So if someone comes back, if patients come back and they've had the lens on for 8 hours or 4 hours and you've got touch, is that touch or is that touch, right? You don't know. So it's very, very hard to figure out how much central clearance you got to increase that so that you don't have touch anymore. In this case, since it was a first fitting, instead of putting a new lens on, I took a gamble and I said, I'm just going to increase the clearance more than I normally would, knowing I should see clearance at my dispense. I then also had to adjust the periphery. And I can tell you right now, I tightened the vertical more than I tightened the horizontal. In this case, the vertical is a steep because the vertical is a flat because my marking's at 65. And then the horizontal is the steep. So I decided to tighten the horizontal just one step because it just said it was slightly flat, but I went 3 steps steeper in the vertical, and I increased the central clearance 300 microns, which is a big central clearance increase, in my opinion. Then we added in our over-refraction. Okay, so now here's our new lens. So we ordered that same base curve. We've got increased sagittal depth to get that increased central clearance, same diameter. And what I say at dispense? Oh, I said, hey, minimal clearance, great, no more touch. Even better, good edge alignment, lens is well centered on the eye. Okay, so nothing bad about that. Could I have probably improved that fit at that dispense? Oh, I'm sure I probably could have. Did I? No, because I'm patient. So I sent the patient away for a week and then had them come back and then checked everything at 1 week to see when they came back. And what did my 1 week follow-up say? It said good centration, clearance is at 260. Look at that. I really did increase that well. Good edge alignment, no problem. Moved forward with that lens. So because I was patient, I didn't end up having to adjust any parameters. And the only thing I would have to do is if there was an over refraction, I may have had to incorporate that in. This was his other eye. How did we one and done it? Ks are not quite as irregular, a little bit closer here, a little bit lower K or K max. Cone is less irregular because it doesn't have that scar that we're dealing with there. Went with the same lens, actually put the exact same base curve on it because I thought it worked good on one. This one actually had lots of central clearance, inferiorly decentered, edges flat, stuff about the periphery. So once again, I tightened this lens the exact same way, but in this case, I decreased it 200 microns, put in the over refraction. There's the lens I ordered, and then said the same thing, minimal clearance, no touch, good edge alignment, lens is well centered on the eye. Brought him back in 1 week. Everything was great. I would probably decrease this clearance a little bit. Especially if I had to put in an over refraction, I would try to get it down below 200. Probably would do it on the other one too, just get them down a little bit closer, but everything went well with our one and done philosophy there. What if you have intacts with your keratoconus? You can approach this the same way. Depending on if they have 1 or 2 intacts and where they're placed, they might actually create a little bit more of an oblate cornea. So you may end up either incorporating in some reverse curve, but I'd probably still start with your traditional prolate design personally on this and just monitor for health. You can see the intact marks there. Here's this patient's eye. Here's this patient's topography. We've got some low points and then some higher points. HVID was a 12.4, so 16 millimeter or larger lens would be great here. K values are in the 40, so we don't have to go incredibly steep. So what lens did we do with this? I put one lens on him. I did a prolate 16 millimeter. It had an 8.4 base curve, which is going to be a 40 diopter-ish lens. His flat K was about a 43. 43 sag toric periphery. Initially looked at it, 294 clearance on that initial lens fit, alignment in the periphery, centered on eye, added an over refraction, saw him back. He had 250 microns of central clearance, 50 at the limbus. Markings were at 165, still aligned in the periphery. That's what it looks like. No blanching, impingement, no over-refraction. He was 20/20. Looks pretty good. That was 2017, wearing the same lens today. Well, not the same lens, but the exact same lens parameters. I haven't had to change a thing since that. Put one lens on his eye, modified from it. In this case, I got very lucky, didn't have to modify a lot. And now we've got that he's wearing the same lens all these years later. Okay, gets a little more difficult when we talk about penetrating keratoplasty. You might be more apt to need an oblate design. I like to make sure I can adjust what's happening over the host graft junction. A lot of times you have this oblate sort of appearance in these post grafts, and you really have to monitor these patients for health, right? You got some neo coming into our graft here. This guy looks pretty good. Here's a patient that I saw in 2023, right? So that's what it looked like. This is what she looked like just earlier last month. We've got a weird sort of Dellen going on. Saw her later in the month. It didn't look near as good, looked even more edematous. I'm having her checked by her corneal doctor because I have concerns about what's happening with her graft. So you want to monitor that for the health. You also, if you happen to have an endothelial cell count, check it, monitor it. There's some information out there that says that maybe 1,000 microns or less on your endothelial cell count, you maybe shouldn't fit, or maybe 800 to 1,000, you shouldn't fit. I don't really think that's a hard, fast rule. I just monitor them, and I monitor them very closely when I initially fit them. So we're talking about, see them more times back than I would my standard keratoconic patient, just to make sure that cornea is looking healthy. So how do you do a fit here? So here's this patient. Here is what her topography looked like. HVID, small. It's got 11 millimeter HVID. Pretty flat K values here. So how do you do? You're just going to pick a lens to go on. I went with a prolate design because she actually had steepening. It wasn't like a transplant that looks very flat. I went with a very flat lens. She was a 37. I actually couldn't get a lens that was flatter than that. So I went with the flattest one I had, which probably was this 39, 15.8. Flat sag. I said there was adequate clearance at 350, limbal edge, no blanching, markings, and I decreased that clearance because I really don't want more than 300. So I decreased the limbal clearance, the central clearance, to bring it down below, to blow that closer to 200 there. One lens on, and that's all we had to do. Dispense that lens. Check it a week later, see what it looks like. Make sure you're still happy with the periphery. Make adjustments if needed. Post-refractive surgery, probably going to need an oblate design. Probably going to look something like this. Have some sort of flattening and steepening. That is this patient right here. So you can see this is an oblate design I have on them that's fit very close. You can see her RK marks right there. Corneal dystrophy, I usually stick with prolate, minimal clearance. Think about ocular surface health, right? A lot of these patients are dry, have some issues with the ocular health. You might have to consider different filling solutions for them to address any dryness or issues they have. This one has Salzman's small diameter prolate, kept it close, nice and flat here. This is a very large lens. This patient has an 18.2. This patient was fitting this lens probably 2009, 2010, in the same lens today. Loves it, but it's a large lens. It's an 18.2. If I refit them today, I'd put them in a smaller lens. He's happy. He sees well. It takes care of his issues. He doesn't have RCE anymore, so I'm not going to refit him because of that. Ptosis. This is very interesting. Think large, think steep, think oblate. All right. You need this elevation in the periphery to lift up that lid. Patient had Bell's palsy in 2021, had aberrant nerve regeneration with resulting in ptosis. We ordered this lens here. We matched up the pupil. You can see we got 3.5 millimeters larger in her palpebral fissure because of it, just because we stuck this oblate, large 18.2 diameter lens on, and it helped elevate that and then pull the lower lid down. So you can see how much you can get there. So large, steep oblate is what you want to think to when you're dressing ptosis. Okay, inferior decentration, very common. You're going to see it a lot. There's a lot of things you can do to address it. Let's talk about one specific example of inferior decentration. Significant with the rule astigmatism. I'm talking about 4 to 5 diopters of with the rule astigmatism, where you have something that looks like this. This is a person that has 5 diopters. And what you have here, when you look at an elevation map, is a situation that's kind of like a saddle in the cornea, or like a Pringle, right? So think about the Pringle chip, right? So we've got flatter, curve like this, and then in the other meridian, you've got a curve like this. I can't make my hand do that, but you got a curve that goes like this. So you're thinking about a saddle. Here's my image to try to mimic that. So you're thinking about a saddle, okay? And then we're putting a lens on the eye that's got a spherical optic zone. Is that going to line up well, right? If I'm putting a spherical optic zone on this? No, it's probably not. And because that flatness is here, it's probably going to contribute to some inferior decentration. So let's look and see what happened. Here's a patient that came in and was fit by our resident. I stepped in, or I saw the patient somewhere around here. So let's just take a look at this. This is what the lens looked like here, number 5. So you can see this lens is very inferior. Here's where we started. Here's the amount of toricity was out there. You know, here's our flat, steep meridians. We went steeper. They went steeper. They went steeper. Okay, we went flatter here, but we went steeper, steeper, steeper. At this point, I'm saying, no, I've never ordered a lens with this type of steepness in the periphery. Something is not right here. So I called up the consultant and I said, there's something not right. You know, the lens looks like it's fine. I don't really know what's going on. We cannot get this lens to center up. The consultant said, is it having a significant amount of astigmatism? And I said, yes, it does. Can we work from the inside out? And they said, yes, we can. So what we did was we incorporated toricity from the inside of the lens, starting in the corneal chamber all the way to the outside. And we ended up with a lens that was centered lovely and beautiful, just like this. So here the lid's pushing on it, but right here you can see when that lid's out of the way, how well centered it is. And this is what this lens is going to end up looking like. You're actually going to have one meridian that's steeper all the way from the central part out. So in the corneal chamber, it's going to be quadrant specific, and then the other one that's flatter, right? So I have my thing here that says when you're in your sclera, this is steeper, plus is less clearance, this is less clearance. So this is steeper the whole way. So we're mimicking that now, like we're making our own Pringle chip, right? Or our own saddle, not chip, our own Pringle scleral lens, our own saddle scleral lens. We're going steeper vertically, we're going flatter peripherally to mimic the corneal chamber, and then a line out there in the periphery to accomplish a lens that becomes well-centered and can actually be centered just like that. We've had to do this multiple times since then. If I have a patient that I'm putting in a lens and they have with the rule astigmatism that is 2 or 3, that is more than 3 or 4 diopters, I automatically start with this design now, and it has dramatically enhanced our ability to have lenses that center on the eye right off the bat. So it's a great way to streamline the fit. Okay, I talk so much that I think I'm out of time, but I just want to real briefly say, if you have a peripheral obstacle, that avoiding the obstacle is truly the best way to streamline your fit here. So instead of putting a massive lens with a massive notch over something, I didn't do this, but I cleaned it up afterward. I'm not sure. I think that might be the world's cutest, tiniest pinguecula. Don't do that. You can microvault, you can notch like that, but if you can actually just avoid the obstacle, that's going to be the better way to do it. So this patient came in, was wearing a 15.8, had worn a 15.8 for a long time, was really starting to get irritation over her pinguecula. And I said, let me see if I can go smaller. So we just went a smaller. I went a whole millimeter smaller, put a 14.8 on it. Loved the comfort, thought the vision was great, had glare at night. So then I went back to the company and I said, oh, I hate to do this because you lose your width out here. So the lens has to land on a lot less space. So it can end up causing some impingement, but I increased the optic zone without increasing the width of the lens, and it took care of her problem, and she's very, very happy. And now she doesn't have the irritation because we actually got inside that obstacle. So if you can get inside those obstacles or just avoid them altogether, that tends to be a better situation, I find, than notching or vaulting in those cases. Okay, am I finished? Ashley, did I make it the whole time I was supposed to
You
go?
did
Okay, I'm
great,
sorry, I went a
Ashley.
little over.
Perfect. So if you could just unshare for a second, I'll share and then
Yes,
we'll get the Q&A.
yes. Oh, I'm
Oh,
still sharing.
love
I'm
that.
sorry. Sorry, everybody. There we go.
Love that. All right. Thank you so much, Dr. DeKinder. That was fantastic, as always. So I just want to give a little plug for next month's webinar. It's with Dr. Zachary Holland. He'll be talking about scleral lens troubleshooting, aligning the sclera with your patient's complaints for success. Here's the QR code, but I do have a few questions for you, Dr. DeKinder. Okay. So what is your lens choice for patients that have post-PRK epithelial ingrowth?
Oh, I would look at the topography and see, and then I'm going to go with, an oblate design if I can do it in the highest decay possible and really try to get as close as I can to, I'm going to fit it as close as possible to the cornea.
Awesome.
I try not to say which lens designs I use. If you want to
Yes.
email me, I can
Yes.
give you a
There's quite a few questions about that. So Dr. DeKinder, would you mind before we log off putting your email in the chat box? Because lots of
Yes,
people want to know
of
specifics that we
course.
can't
I'm
necessarily
always,
talk about.
always happy to answer
Okay.
emails.
Okay. So for the patient that had the neovascularization, do you
Yeah.
anticipate after the photocoagulation it coming back or reoccurring?
Yeah, I think that that's an excellent question. And she just had that laser procedure performed earlier this year. So I'm going to be watching her closer than normal. Here is my thought on this. That patient was fit in that scleral lens almost immediately after after her herpetic incident had created that large scar. And the neo started almost immediately after that. And I monitored it as it slowly grew for years and years. So I have always said to myself, would she have gotten neo anyway, or did my scleral lens cause this? I
Right.
don't know, but she can't see without it. So the point is she needs the scleral lens to see. So we just kind of monitored it, and I worked with the corneal surgeon the whole time. Now that it's been photocoagulated, will it start growing back? And I'm just going to monitor and find out. I have a funny feeling that I'm going to find out really quickly if it's the scleral lens that's doing it or not, because I think that we'll start to see some of that come back. But the nice thing is, because it took so long to grow the first time, I think I can just slowly monitor it and use the same interventions with steroids and just monitoring it for several years before we have to do something again.
And do you think fenestrations would have helped prevent that at all or prevent it in the future?
Oh, I'm not a big fan of fenestrations, and I don't really feel like I have evidence that proves that they would have really helped it. So no, I'm going to say no, but that's just my practice philosophy. And if people, and I do know of people that use fenestrations. I know a lot of pediatric with it fitting a lot of scleral lenses, pediatric scleral lenses, they use fenestrations and stuff. I just don't ever think of them as a good troubleshooting in my practice.
Got it. Um, let's see, there's several here. Would you use an oblate design for a regular cornea with a high minus RX?
Yeah. I mean, if that's what you need to get it to fit well, especially if it's one of the flatter cornea. So if they've got a flatter cornea and you like an oblate design, the way it looks better and it gives you the limbal clearance you want, absolutely nothing wrong with them. I mean, I will say that early on, I almost exclusively used an oblate design because I really liked that lens. And now the lenses that I use tend to, you have to incorporate it in yourself. So that is why I would say, yeah, sure, that there's nothing wrong with using an oblate design at all. You can always manipulate it by changing the base curves to get what you want.
It's true. So this is a little bit of a lengthy question. So when assessing the location of the markings to tighten the peripheral landing zone, are we mostly determining whether the markings are more vertical or more horizontal? And what happens in cases where the markings are at oblique angles?
Nothing. I determine the markings so that when I am talking to the consultant and I'm telling them how much I want to change my periphery, steepen or flatten it, I always tell them where those markings are, so that they can better change the fit of the lens. the location of them becomes even more important to the degree of, oh, I measure to the exact degree when I'm adding a front surface toric optics onto it, because that's how they're gonna know how to put the power on. So that's when it's so important to have them specifically marked. And that's why I mark it every time, because I never know when I might need to transition to putting a front surface toric on the lens. But when you're actually adjusting the periphery, I find even if they're at oblique, when you make those changes you want, that lens is going to end up locking in. So when you make the changes you want and it's tightened closer, it's going to lock in a little bit. And then you might find that next time you look at those markings off of your fit, because you've tightened it up, they're not really oblique anymore. They're here, or maybe they have become oblique at that point. But that's because that was that lens just finding its spot when you got it better well aligned to actually sit evenly out there on the sclera.
Can you give us kind of an overview of how you are measuring haptic locations? There's a general question about just how you're measuring, like, the rotation of the lens.
Yes. So I take an optic section with so I'm in the slit lamp. I have a white light optic section, get it nice and focused, and then I actually move my beam, and I line my beam up, and I align it to where, because there's going to be two markings, right? So they're going to be 180 degrees apart, and I line that beam up equally with both of the markings. Even better if it goes right through the center of the pupil, but if the lens is sitting a little inferior, it might not. You line it up with both, and then I just read the axis off of the top of my slit lamp, whatever axis that is at. Now, if you do not have a slit lamp that does that, that shouldn't deter you from being able to figure these out. Think about when you're doing, your phoropter or your refraction, or thinking about how much a toric lens is rotated, and think of a clock hour as 30 degrees, and just look and see where they are, and if they are, instead of, let's say the markings are here, but they're actually kind of like off this way, and it looks like, oh, it looks like it's about 7 o'clock. Well, then I would probably put in my chart 30 degrees rotation, temporal, nasal, clockwise, counterclockwise, however I note it myself, or look like marks were at 7 o'clock if I can't measure specifically to the degree.
So in a situation where there's inferior decentration, what is your first step to troubleshoot? Do you tighten the periphery or change the diameter?
Oh, no, I don't think about changing. I rarely change the diameter of a lens. My first step is always tightening or steepening the vertical haptic, whether that's the steep, the flat, whatever it is. And if it is significant inferior decentration, I'm definitely going to go 75 to 100 microns steeper there, because it just tightens it and it just lifts that whole lens right up.
Okay. During the case when you talked to the consultant about the inferior decentration, the lab asked you something specific about the patient that this listener missed. Could you repeat what they asked you?
Yeah, they just asked, does this patient have a lot of with the rule astigmatism? Like, so they wanted to know what condition I was fitting, because, I came to him and said, look, I fit these for a long time. I know what I'm doing. Why can't I get this lens to center up? It doesn't look like there's anything, crazy going on in the cornea. And they said, what condition are you fitting? And I said, high with the rule astigmatism. And then it just kind of, about the time they said, have you thought about doing, I mean, I guess it could be called like bi-elevation or quadrant specific corneal. I thought, oh my gosh, could that be what's going on? And then we designed the lens. And I think you're seeing I'm sure every manufacturer has this option out there. I know one of them markets a specific lens for it. That's not the lens I used. We actually designed this one ourselves, but there's lots of these on the market to do that sort of saddle shape lens now.
Okay, last one. Do you wait to finalize the fit before adding in a front surface toric power?
That is such a good question.
Mm-hmm.
And it really depends on how comfortable you are with what you saw. So if I am making what I consider to be minor modifications to the periphery, and what I'm going to say a minor modification would be maybe only going 25 to 30 microns steeper all the way around, or in one meridian or the other. So I don't think what I'm doing to the periphery is going to impact the rotation of the lens very much. Then I am going to push the consultant to allow me to put that front surface toric in from the get-go, because I know it's going to help my patient. if I am making a large peripheral change, if I am doing one of those situations where the lens is inferior and I also felt like it was moving on the eye, so I am truly going maybe 125 microns to 150 steeper in one meridian or both, I am probably going to tell the patient, I'm not going to put this whole prescription in right now because I want to do it after the lens fits better on your eye. But even with my one and done philosophy, if a lens is kind of moving on the eye and I have to make those big changes, I might toss that design and just switch to another design right off the bat. Because if you're making that big of changes, it makes you wonder like what it's going to look like after you get them going. So I do put it in a lot if I feel comfortable with where the lens was and how long it's settled. And you know, whether my consultants like that or not, I don't know. But if I was making massive changes, I wouldn't.
Got it. All right. Thank you so much, Dr. DeKinder. That was fantastic. So I just reposted her email address in the chat box. So please, if you want to ask her more specifically about lens brands and those sorts of things, we can do that off the webinar. Okay. Thank you so much, everyone. Have a wonderful evening. We'll see you next month.
Thank you.
Good night.